Welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
Hello, my name is Rohith Bhethanabotla, a fourth-year medical student from Drexel University, and a co-author on a recent paper titled Cost Comparison of Industry versus In-House Three-Dimensional Printed Models for Microvascular Mandible Reconstruction from the University of California, San Francisco. In this study, we wanted to answer the question, can surgeons bend plates for microvascular mandible reconstruction using a 3D printed model of a jaw instead of relying on customized industry-built patient-specific implants for less cost? And so in our study, we compared the cost of industry-performed patient-specific milled locking reconstruction plates versus surgeon-performed plate bending using 3D printed models from hospital financial database data. And we found that surgeon-performed 3D printing was less expensive than computer-aided patient-specific plates without significant differences in patient characteristics, number of osteosyntheses on CT scans 6 months post-operation, and instances of osseous union observed for mandibular reconstruction. Ultimately, the results suggest plausible use in higher volume centers, although further research would be necessary. So here with me to talk more about the paper is senior author, Dr. Daniel Knott, Director of Facial Cosmetic and Reconstructive Surgery within the Department of Otolaryngology, Head and Neck Surgery at UCSF. How are you doing today, Dr. Knott?
I'm doing great, Rohit. Thank you so much. How are you?
I'm doing well. So today I wanted to ask a few questions about the motivation behind this research and kind of get a sense of the study design and methods and implications and broader applications of this research. Are you ready to get started?
I am. Thank you so much.
So the first question is kind of a broad question. What inspired your team to explore the use of 3D printing and the CAD/CAM technology in mandible reconstruction surgery?
Well, Rohit, it really was threefold. The first reason was that the use of industry-performed 3D modeling and CAD/CAM technology is expensive. Typically, it costs in the order of $7,000 to $15,000 per case. And if patients are supported by government payers, that essentially goes unreimbursed. Number two, the process is tedious and long, and it oftentimes requires 2 weeks turnaround time after getting CAT scans, setting up conferences, getting the manufacturer of the equipment and the plates. So there's a delay in some cases, for some of our cancer-related cases that I've found to be problematic. And lastly, it's cumbersome because it requires the scheduling and then the performance and coordination of a conference with the designers of the company. And I found that sometimes was hard to coordinate with my schedule, as opposed to the other opportunities that I developed.
Got it. So one question that kind of came up was why mandible reconstruction is complex and why precise shaping is even necessary to patient outcomes. Could you explain a little bit more about that?
Yeah, so I mean, ideally, every patient essentially wants to look, quote, normal after their surgery and to look as close to their preoperative um, um, maligned looking face and jaw as possible. So getting a jaw that, number one, is symmetric, number two, offers the same projection width, and then maintenance of dental occlusion is really important for our patients. If you're going to be having a critical gap in the bone of more than 5 centimeters, the use of non-vascularized bone grafts has an increasingly high failure rate, which is why we use vascularized bone in these cases. If patients are going to get radiation and it's malignant cancers, then non-vascularized bone grafts are not available or are not compatible with that. And so if you're going to be doing vascularized bone grafts, then you really need to be extremely precise with the planning such that the bone edges come together with less than a 1 millimeter gap between the successive segments to give patients the highest chance of union to be established afterwards.
So in the paper, it's mentioned that 3D printing and CAD/CAM are increasingly being used in reconstructive surgery. What are some of the initial challenges faced when implementing these in the operating room?
Well, the models need to be able to be sterilized if you're going to use them intraoperatively. So that's a problem. So there's a variety of different technologies used for 3D printing. And so some of the technologies use plastic, some use carbon fiber, some use fiberglass, some use metal. And so if you're going to be using a technique and sterilizing it, it has to be able to be sterilized and have medical investigations and an industry supported certificate that shows that it can be sterilized, and then you have to have the ability to have the correct sterilization technique, Steris, gas sterilization, heat sterilization, whatever it is you're using, that the model can withstand that technique. And then also importantly, you need to have a material that is going to be able to be strong enough to resist the pressures of bending the plate up against it.
And for listeners who may be unfamiliar with the process of CAD/CAM development using milled plates, could you explain a little bit about how those are done and how that process kind of looks like?
Yeah, sure. So it requires the acquisition of very fine, thin-cut CT scans, typically 0.0625 millimeters thick. And then, so you're talking about hundreds of cuts to cover the entire mandible. This needs to be uploaded to a CD that can then be given to either a representative or sent to the company in some way, shape, or form. So that way they can upload the CAT scan imaging into their database. They can then remove all of the soft tissue elements to isolate just the bone. And then they can actually, using the computer technology, create a plate that will exactly fit the contours of that bone. Or you have to have a conference that you schedule with the company that allows you to show them and have very predictable cuts through the mandible of where you're going to do the segmental mandibulectomy. So that way the plate can be bent to the fibula graft that's going to be planned to fit. This is important if patients are going to be getting simultaneous same-day dental implantation, because you want the fibula bone segment to fit in only one way up against that plate, such that it's predictable and the implants can be put in the correct position. Then a milled plate, as you mentioned, milling is a technique where you have a block, like literally a large block, like a brick of titanium. And the process selectively removes the titanium, leaving the plate untouched in pristine metal condition. If you take a flat plate and you bend it enough, each bend you make in it causes metal fatigue and challenges to those in metallic bonds of the metal that then can lead to weakening and fracture. So a milled plate has undergone no bending at all. It's almost like, melting away a block of ice to reveal an inside structure, or, Michelangelo carving David out of a block of marble. It's the same idea. So those milled plates fit in specifically to that patient's inherent mandibular anatomy.
For an institution that might be interested in getting involved with 3D printing models, how accessible is this technology, and what would you recommend institutions do to get this process started?
Well, 3D printing has so many applications across different specialties. So ideally, a large institution would have a consolidated 3D printing program that's in-house. If that's the case, it makes the user's job much easier. In our case, we hadn't yet developed that at UCSF. And so we purchased our own 3D printer, which was the main cost for the project, because at that time, the quality printer we wanted cost around $18,000. And now there's, much cheaper options available if you're going to purchase your own 3D printer. Otherwise, just use your institution's 3D printing laboratory, and then you just need the software. And so the software we used in our study was available for free on the web. Protocols have been published about this, and I recommend anyone who's interested to try to play with this software that allows you to select out only the bone based upon Hounsfield units, so that you can basically subtract all the soft tissue away from the CAT scan, leaving just the bone. And then it allows you to do lots of fun things where you can like remove the tumors digitally, so that if an exophytic tumor is precluding the bending of a plate, you can surgically remove it on the images. That way you can actually create a model that is smooth and would actually correctly, faithfully pose to the mandible after the tumor has been cut out.
When you were using the 3D printed models, did you happen to see any changes in surgical outcomes or any differences in patient recovery compared to the CAD/CAM models or CAD plate?
So I would say the main advantage was we could do this overnight. You could actually, I could download this, I could upload the CAT scans that we had obtained in-house to the databases, and then I could play with the online free software at my leisure. And invariably, we have downtimes during our day. As someone's being intubated, as case turnovers occur, that's unpredictable. And so to be able to log on and take advantage of that downtime to do all the modeling was really easy and fit much easier into my schedule than a conference that I had to plan a week in advance. And so that allowed me the rapid turnover time. I could literally print a model overnight and be ready for a case the next day. So I think the main advantage to our patients was that rapid turnover time.
More broadly, beyond mandible reconstruction, how do you see 3D printing evolving in other types of reconstructive facial plastic surgeries?
Oh, I mean, it's been used extensively in facial feminization and masculinization surgeries for operative planning to create cutting guides, cutting templates, to plan your operations and actually have a three-dimensional structure like a sculpture that you can use to help guide your operations when you're in the OR. It's been used for rhinoplasty modeling. It has extensive applications for otology, where you can actually create simulators and use a material that is very like the structure of bone for residents or trainees to use to do simulated temporal bone drilling, for example. And I think there's so many applications, Rohith, that we don't know about yet that will become more clear as we move forward with this.
And lastly, for any newer surgeons listening today, what advice would you give to them who are kind of eager to work with these kinds of novel technologies in 3D printing? Is there anything that you learned along the way in structuring this study or developing the models that you would recommend?
Well, I would say the one of the main reasons that I got into this was by talking to people. One of our fellow applicants for our facial plastic fellowship is the one that gave me the protocols for doing 3D printing, networking, finding out other people have done, picking people's brains, sharing ideas. And it's always fun to publish in new avenues of research, new opportunities, new technologies you mentioned. So these areas are ripe for innovation, and you don't innovate alone in a bubble. But it best occurs by having a fertile imagination and then a fertile interaction with colleagues and other people, both inside and outside of your field of interest. Because you'll be amazed by the innovations that are occurring in orthopedic surgery, urology, and neurosurgery that have direct applications to our field that nobody has quite thought of yet.
Thank you for answering all the questions, Dr. Knott. It was a pleasure working with you on this paper. And just, do you have any other things you want to add, or?
No, I would just say that, again, the in-house 3D printing technology really does not offer a ready solution for dental implantation. And so for simple bending of plates to use intraoperatively, having a model allows you to bend the plate on the back table, again, at a downtime that I find to be very time savings and useful for the operations, but it doesn't currently allow me to create models for dental implantation. So there is a huge area of great improvements offered by the industry-supported modeling technologies, but there is a niche for in-house printing, and it's a question of finding out where those niches are and how to leverage that to save the system some money and make the whole system a bit more flexible and time effective. Rohith, pleasure working with you on this as well. Thank you so much for all your strong work and accomplishments.
Thank you, Dr. Knott.
We'd like to thank the authors for their commentary and thank you for listening to our podcast. If you'd like to explore more, please feel free to check out the article in print at the Facial Plastic Surgery and Aesthetic Medicine Journal or online. We'll catch you on the next one.